Okay. Good morning. We'll get everything kicked off this morning. I know for the small amount of people we have in the room, this seems absolutely silly to be using a microphone, but we also have quite a few people on Zoom joining us. Hi, Zoom participants. I think everybody in the room I have checked in, so you are good to go. Again, required if you are receiving CEU credit. Even if not, it's something we like to have to see if we are growing this program, and that is our hope. So we appreciate you checking in and out. Virtual attendees, you don't need to do that just by virtue of logging in. We have got your attendance. And I should probably say who the heck I am, right? Hi, Lori Smith. I have been with Direction Home for about 10 years in the communications department doing the training. Quick reminder for our virtual attendees, and you can see that on the slide right now. Uh, Please make sure that your name is viewable if it is not already. And that is, again, especially important if you're receiving CEU credit. If you are logged in under someone else's name, I can't verify that you have attended and I can't offer you the CEU credit that you are earning right now. So please make sure that your name is visible in the window. Please make sure you're muted and camera is off. That just helps to keep distractions down. And then have that chat window open if you don't already have that. I have put in the chat window a handout that our speaker Austin will be referring to, and I'll drop that in again if you joined us after I had put that in the chat. And then when we are done today, I will also drop the link for the CEU evaluation that is also required to get CEU credit. In-person people, there will be a QR code that you can access, or you can see me at the check-in table and do it there as well. So I think that is everything that I have as far as housekeeping. Oh, I lied, as I often do. Um, our virtual attendees, Q&A. If you have questions as we move along, please feel free to drop those in the chat window as we go through the presentation. And then once Austin has wrapped up, I will read those to him and then get those answers for you. Now I'm done. So I am thrilled to present Austin Northcutt. He is with UH Hospitals, that seems redundant, University Hospitals, and he is a speech therapist here to talk about vascular dementia and aphasia. So I will pass it off to our superstar today. Thank you.
Hello. A- As Lori said, I'm Austin, and I am a speech language pathologist, is the technical title, but speech therapist is what I tell everybody because no one remembers speech language pathologist. So in my current role, I work with university hospitals, as Lori said, in the home care department. Um, and I cover a very large area, but see patients across a lot of Northeast Ohio in home, anywhere from swallowing to language, cognitive issues, and quite a large part of my caseload is patients with aphasia following a stroke, and because of that, a lot of vascular dementia as well. So we'll be talking about a lot of different stuff today, and as Lori said, I will have some time for questions at the end. Yeah. So we're going to talk about warning signs and causes of CVA, which is a cerebrovascular attack, more commonly known as a stroke. There's been a push over the last decade or so to change the terminology from stroke to CVA, due largely to um, a lack of understanding about the seriousness of a stroke. A lot of people would view a heart attack as something very deadly or dangerous, but wouldn't put the same stock in something like a stroke. So there's been push to change the terminology, but it's the same thing. So either way, I'll probably refer to it as both throughout the presentation. Just general stuff. A lot of you may already know this, but a stroke occurs when the brain is deprived of oxygen. There's two main types of stroke. So we have one that's caused by a blood clot. This is called an ischemic stroke. So a blood clot will go into a vein or artery within the brain, preventing blood flow and then oxygen from reaching a specific area within the brain. The other type is due to a brain bleed. This is frequently called a hemorrhagic stroke. The brain bleed can happen for different reasons. Um, Sometimes there's a rupture within the brain, like an aneurysm. Sometimes there's a car accident with a traumatic brain injury, a fall, concussions, anything along the lines that leads to uh, the brain bleeding. And as that fluid enters the skull, the blood enters the skull, there's not anywhere for it to go. So it increases that pressure. And as that pressure increases, it can't push out because of the bone of the skull. So it pushes in on the brain, cutting off that blood supply. Similar to if you tied something around your arm, you would stop getting blood to the rest of the extremity. And depending on length of time, things like that, the damage will vary. I will say that typically a hemorrhagic stroke is more severe due to it damaging a larger space of the brain. So, an ischemic stroke can be very damaging and can be very serious, but typically is just one area of the brain that has that oxygen cut off. And when we talk about severity, there's a lot of different factors that play a role. So, if a patient has had numerous strokes, then the effects stack on top of each other and can result in more serious effects. If the stroke is left untreated, um, that's another big warning sign. If we don't take care of it, then that blood clot might be in place, cutting off that flow of oxygen for a very long time. I've seen patients that have never had treatment for a stroke because they didn't know they had one until a year or so later, and they found out and they said, "Oh, okay." And the blood clot eventually resolved itself, but um, it's not good if we don't treat it because our brain needs oxygen, or it doesn't do what it's supposed to. Um, I also felt it was necessary to include the warning signs of stroke. The common acronym is FAST, so F for face, meaning that there's that facial droop to one side, typically. Inability to smile, the smile's not symmetrical, things like that, any change in facial symmetry. Um, A is for arm, so inability to move an arm on one side, weaker, less fine motor movement, weak grip, sudden change that way. S for speech, so speech might become slurred. It might sound like the person is intoxicated. They are not usually, but or it might be something like the words don't make any sense. They can't come up with the words. They look scared because they can't get words out. Anything along those lines. With T standing for time, indicating that we want to get someone to the hospital as soon as possible to get treatment as soon as possible to prevent any long-lasting damage. So calling 911 as soon as any of these symptoms start to happen. I include this because anyone who has had a stroke is more susceptible and at risk for a stroke later. So if you're working with patients or have a loved one who had a stroke, hopefully they're on some sort of therapeutic medication to help limit that risk. But just having had one in the past increases that inherent risk of stroke. Another thing that is similar to a stroke is a transient ischemic attack, or a TIA. They're frequently referred to as mini strokes. So it's when there is a temporary blockage of blood flow to the brain. That blockage might be complete like a stroke, but it doesn't last for very long, where there's complete blood flow cut off and then it opens up. It could be due to plaque buildup. It could just be due to poor blood flow. Um, and I see quite a few patients that have them, and they become somewhat normal for them. Um, if they continue to happen over time and continue to occur, similar to more strokes happening, that damage can stack up and lead to deficits that are very similar to a stroke over time. So it's definitely a serious thing that can happen, but isn't always given proper weight. And then I wanted to talk briefly about CVAs and communication. So when we talk about when communication is impacted with a stroke, it typically is on that left side of the brain. So I have a very simple diagram of the brain up here. There's two big areas that are responsible for language, Broca's and Wernicke's area. We'll talk more about them specifically later, but I've included them. Those are on the left lobe of the brain. So typically, if someone's having speech difficulty in terms of language processing, production, it's a left-sided stroke, which would then result in that right-sided weakness because everything with the brain is flipped. Now, this isn't 100% true. So the brain continues to be a mystery for a lot of things with research and trying to determine things. There's some research to suggest that left-handed people have their language controlled on the right side of their brain. Ultimately, it doesn't really make too much of a difference, but Typically, left-sided strokes are where we'll see that language deficit. And again, those deficits depend on a variety of factors. So I want to be clear that when I'm talking about examples or what can be done to help support a patient who's had a stroke, everyone's different. I've seen hundreds of patients with strokes, dementia, and I can't think of any that I would say were the exact same and the exact same thing worked or the deficits presented the exact same way. So the location can be a big factor. So even if it was a mild stroke that got treatment really fast, if the location was right in one of those main areas for language, that person could be doing really well physically, but have some really severe communication deficits because of it. So it's not always what it seems. Now, with length of time or with like a hemorrhagic stroke where it's a more wide encompassing because the brain bleed tip isn't always centralized in one area, it might be the entire brain was affected, and then you might see those deficits in line with physical status as well, but not always. And those communication deficits can present in different ways as well. So the main focus for today is going to be talking about aphasia, which is a language deficit. Some other ones that I might mention a little bit, but aren't quite as important to the presentation today, would be dysarthria, which is a muscle strength and coordination deficit. So typically a patient with that might have more slurred speech. They might have a lot of nasality in their speech, like sounding like they're talking with their nose plugged the whole time. They might have difficulty with specific sounds. And then apraxia is a motor planning and execution disorder. So with apraxia, the person has the physical strength to complete the task. So for example, they could blow out a candle and they could make their lips and the articulators move that way. But maybe when they go to make a sound that uses the same function, they're not able to. So there's a connection difficulty within the brain. Again, there's not as much in terms of support as for a caregiver or a loved one in here outside of just being patient and letting them work through those articulation difficulties, which is why it's not as much of a focus today. And then briefly before we move on to talking more specifically about language and communication, I wanted to touch briefly on vascular dementia. Dementia is a term that has a lot of stigma with it. It is something I'm sure everybody has heard of. I've never met anyone that hasn't heard of it, and it can be a dirty word where people don't like to talk about it. Vascular dementia is a very specific type of dementia. Getting a specific diagnosis of any type of dementia is not always easy because there's not a perfect way to tell when it comes to dementia. But typically, if a person is presenting with that cognitive difficulty later in life and they have a history of stroke, CVA or TIAs, it's likely vascular dementia. But it isn't too different from standard dementia. It just is paired with those communication difficulties that have occurred due to the stroke later in life or due to that stroke damage. That difficulty might present later. So the more stroke someone has or the severity of the stroke might lead to higher risk for vascular dementia. Not every person that has a stroke is going to have vascular dementia. It just depends. There's a lot of different factors, genetics, things like that also play a role. And any damage, so it doesn't have to be a stroke or a TIA, but traumatic brain injury, frequent concussions, anything like that can lead to that vascular dementia. It's not specific just to TIAs and strokes. Symptoms can be pretty general. Dementia symptoms, confusion, difficulty organizing thoughts, difficulty orienting, not attending very well, just generally confused. There might be more of a language component with it, typically. So difficulty finding words with that aphasia, having poor grammar, the sentence is just not making too much sense, inappropriate comments with that social language communication playing a role as well as possible. All right, so now we're going to talk about aphasia a little bit more specifically. I was a linguistic minor in college, so I love language. So I included a brief mention that aphasia is originally from Greek and it means speechless or lack of language. So that doesn't really matter, but I like it. There's two main, yeah. Yeah, absolutely. Patients tend to appreciate the explanation as well, because it's a word and we get thrown a lot of diagnoses and different terminology, and it can be overwhelming. So having some explanation, I think, helps sometimes too. And yeah, there's two main types of aphasia, um, generally. We can talk about expressive or receptive aphasia. So it applies directly to language. So expressive language is your ability to verbally communicate or non-verbally communicate, anything that you're producing to communicate with a communication partner or to a group or a caregiver, loved one, anything under that umbrella. So the ability to produce language is impacted. This might look like word finding difficulty. So the person says, I can't think of the word, or it's on the tip of my tongue. They might stop in the middle of the sentence and completely lost their train of thought. They don't know where to go, and they just feel stuck. Word selection can be impacted as well, where they're using a word that just doesn't really fit with what they were saying. So completely swapping a word that seems out of left field can happen. Just lack of understanding about words can play a role there as well. And then grammar can be impacted. So speech might be a little bit more telegraphic, meaning that it's short. We're leaving out function words. We're using verb tenses incorrectly, things like that. Receptive aphasia applies more to the ability to understand language. So how are they able to follow directions? If there's multiple people talking, is it really hard for them to pick up everything that's being said to them? As well as monitoring their own productions. So a patient with receptive aphasia frequently might not even realize that what they're saying doesn't make sense. To them, it makes perfect sense because they think they're saying exactly what they want to. Um, they might have said, I want to go to this. In their head, they said, I want to go to the store, but what came out was the dog is blue. And you're saying, that doesn't make any sense. I said, well, why not? I said what I wanted to say. And it depends. Again, every patient is different. Um, it's different patient by patient. So no one of these deficits is going to be 100% consistent. I will say the word finding tends to be pretty consistent with aphasia in some form of another, as well as following directions being impacted to some level when there's receptive aphasia involved. So it might be trying to break down directions to be more one step at a time instead of giving multi-step directions where it gets a little bit more complex. If we want to get a little bit more specific about expressive aphasia, there is fluent and non-fluent aphasia. So fluent aphasia is also called Wernicke's aphasia because typically the damage is located in Wernicke's area of the brain. And that area of the brain is responsible for producing good fluent speech. So when I say that, fluent means no unnatural pauses, no stuttering, no gaps in speech. It's not halting, so it sounds really smooth. It might sound like they're speaking a different language, depending. I've had patients in the past with Wernicke's where they can talk up a storm, but nothing they say makes any sense to anybody. But to them, it makes perfect sense, which can make it very frustrating for the caregiver and the patient because they don't understand why they're not being understood. So that poor self-monitoring comes in hand a lot with that type of aphasia, where they don't always realize that they're not being understood until they look at the person they're talking to and they see their face and realize this person doesn't understand anything I'm saying, but they can't redirect to fix it. And it's not always that way. It might just be random words getting plugged in. Completely unintelligible speech is definitely on the more severe side, and there's different levels across the board. Wernicke's is also less common. I've seen only a handful of patients in my time with Wernicke's aphasia. Typically, I see more patients with non-fluent or Broca's aphasia, which occurs in Broca's area of the brain. That area is responsible for finding words and word acquisition, grabbing specific the words that you want to say. So the speech for a patient with Broca's aphasia or non-fluent aphasia might be more halting. There might be a stutter component, difficulty finding words, unnatural gaps. Self-monitoring and receptive skills vary person by person. So It's very possible that a person will have a really hard time finding words, but be completely cognitively intact, fully understand the deficits that they have and what's happening, which sometimes makes it very frustrating, and can lead to shutting down, not wanting to communicate, things like that, just due to that frustration. It's also possible to have some pretty severe cognitive deficits paired with it. So, and receptive deficits, it really just varies person by person. Okay, so what does aphasia look like? Um, it can look like a lot of different things, but in general, the key when I get a referral from someone who is not as familiar with it or a family member talking about it, typically it's just they have really hard time finding words. Um, they say, I can't come up with it. It's right there. It's on the tip of my tongue. Short sentences, like I mentioned earlier, that more telegraphic speech, I go store, things like that, instead of I go to the store, dropping out unnecessary things because it's more challenging to produce complex language. Um, that halting speech where there's a stutter involved, we're stopping, we're starting, we're pausing to try and think of the word that we want to say. Um, Anxiety, frustration is a very big part of aphasia. Whether the person recognizes their deficits or not. If they're not aware, then they're frustrated with the person they're talking to because why do you not understand what I want to say? Why aren't you doing what I asked you to? Um, and if they do understand to some level or completely, frustration with themselves because why can't I do this? I've talked for 60, 70 years and never had a problem. And now all of a sudden I have difficulty with it and it sucks. It's not fun. Or frustration with communication partners trying to do what they think is helpful and it's not always helpful, which will be part of what we talk about shortly. Stuttering can happen for different reasons. So sometimes it's due to that dysarthria or apraxia we talked about earlier with a motor issue. Sometimes stuttering occurs when your mouth doesn't work quite as fast as your brain. So there's a disconnect there, and that stutter might occur to pause and give more time to catch up. So patient by patient, it just is dependent. And then just difficulty communicating is the basic way to explain aphasia. Language is a challenge, and what may have been really easy, and they may have really enjoyed being social, now socialization is very taxing for one reason or another, just because the act of talking is exhausting for them. Okay, so now we're going to talk a little bit more specifically about what communication deficits might appear and what we can do about it and what we should not do about it. So a little bit more about deficits with aphasia. Again, every individual is different, just like every person ever. No one is exactly the same. It's rarely just word finding difficulty. It has happened before where it's a very mild stroke. They sometimes have some word finding difficulty. We work on some strategies. They're good to go. Nice and easy. Now, sometimes there's cognitive deficits paired with it, which can be a challenge just because cognitive deficits on their own are enough of a task in terms of safety awareness and communication. There can be a receptive component with it, just not understanding what's being asked of them, poor self-monitoring, all the things we've already talked about. So a lot of different things that can present and pick and choose. Each patient is completely different. Some of them will have one, some will have all, some will have two. It just depends. Stress and frustration tend to exacerbate and make it worse. So my number one recommendation whenever I get started with a patient is to take a deep breath. Anytime I'm with a patient and they're frustrated, take a deep breath. You try and brute force it and force through to find that word or to get that speech out, you're just going to drive up your blood pressure and you're just going to be more frustrated. So that frustration is very common following a stroke in general, but that communication component can be very frustrating, especially for a patient who might have been extremely social beforehand and like to talk, and now they can't. I will say that swearing tends to remain, regardless of what kind of aphasia a person has, regardless of how severe. I have yet to meet a patient who could not swear like a sailor if they so decided to. So a lot, not a ton of research on why that is, but that is just my observations, and it seems to be reinforced when talking to colleagues. Um, a lot of it probably comes back to that more instinctual response. When you swear, you don't really think about it, which is why we usually have a hard time censoring ourselves around children if you're not around them a lot. So when you don't think about it, that's when the language tends to come, which is why we want to decrease that stress. So don't be surprised if you're around someone who has a stroke. They have a hard time communicating, but they can swear at you very easily. Very common. Okay, so what do we do to help? I would say ask. Talk to the patient. I am very big on open communication. Now, depending on the severity, obviously that might be easier said than done, but I think it's still worth trying. And it doesn't have to be, what can I do to help? Because that can be a frustrating question for anybody. Well, I don't know. But asking, okay, was this helpful? When I do this, does that help you? Or when I do this, is that counterproductive? Does this frustrate you? Patience is key. So, being okay with silence is a really big part of supporting someone after a stroke. As human beings, we don't like silence, and we tend to jump in to try and fill it because we get uncomfortable with it. It was something that was challenging for me when I was going through grad school, and you kind of just have to deal with it. So just wait. Waiting for them to work through it, waiting for them to come up with a word. The more you try and plug in, it doesn't always help. But asking guiding questions can be good. So when we talk about conversation, conversation is obviously a two-way street typically. For our circumstances, I'll say it is. So there's the person who's had the stroke, there's the person who hasn't had the stroke, and you guys are working together to communicate and understand each other. Now, typically, that split is 50-50. So it's on the person talking to make sure they're communicating effectively. If the person listening is not understanding, it's on them to ask questions and to try and understand. Now, after a stroke, that burden shifts largely to the person who has not had a stroke, because communication, just for them to produce anything, can sometimes be a challenge. So it's up to you to drive that conversation forward sometimes. If they're trying to come up with a word and they just can't get it, well, they're trying to talk about where they want to go to eat. Okay, well, is it close to here? Do they serve burgers? Things like that. Trying to understand, just like if you're talking to someone, they can't remember this actress, and you say, okay, well, what have they been in? So asking those guiding questions to kind of work towards the goal together. I also never accept forget it in a speech therapy session. Sometimes it's easier said than done with loved ones. Um, Caregivers tend to bear the brunt of a lot of frustration. So when I'm doing a session, I've spent 20 minutes trying to figure out that the person watched the Masters over the weekend, because I just didn't understand what they were trying to tell me, and we worked together to get there. But the joy that the patient felt, the success to communicate that, was it the most important thing? Probably not, but because they wanted to share it with me, I felt it was important. So I never accept forget it, or it isn't important, because if you felt the need to communicate it to me, it is important, and I want to make sure we get there. I'll also say that less is more. So when we're talking about receptive aphasia specifically, less is more. So when you give someone a direction, the normal processing time for any person probably isn't very long, maybe milliseconds, maybe a full second, depending on how complex the instruction was. Now, if you think of just a random number, so 10 seconds maybe. So if this person needs 10 seconds to process what's been said to them, and then they can act on it. Well, if you repeat the instruction, that 10 seconds starts over. So if you've said, let's put on your shoes, and they're just sitting there, it's been 2 seconds, you say, put on your shoes. Okay, well now, instead of 8 more seconds for them to process, we're another 10. Put on your shoes. Or I've co-treated with occupational physical therapy at times. When we're working on like transfers or ambulation, it's, okay, pick up that foot, now put it down, pick up this foot, and it's, okay, they're having a tough time following all those instructions of bend at the knee, lower your back, reach back, all at the same time. What can we cut out? A lot of those movements are natural. So what can we do to limit the information coming in? The patients typically have less bandwidth than we do. So trying just to cut back on what we can do and limit the amount of information we're giving to them, because it can be a real load for them to process all that information. And you might see it if you're talking to someone, you ask a question and you sit and you wait, and then 2 minutes later they respond to the question and you say, what are you talking about? And, oh, I asked you that question 2 minutes ago. Well, they've been thinking about how to respond to it this whole time, and you moved on because you have a typically functioning brain and you're ready to move on with the conversation, but they're still thinking about it. So just being aware that processing is not always the same. And I'll also say that a lot of the nonverbal cues, or the cues that we give others during conversation, aren't always used for a patient with aphasia. So a normal person might say, or they might do something with their face or their hand to signify that they're thinking about it, and that's why they're taking time. If a person has aphasia or vascular dementia, they might just stare at you. And you say, okay, well, do you not understand? Or did you not hear me? And then we repeat because we want to make sure we're being clear. And there's no perfect solution. It really is patient dependent. So you have to get to know your patient or your loved one and what's best for them, which is when I come back to asking, okay, well, do you prefer that I wait? And sometimes that process time isn't always the same. If they're tired, everything gets harder. So at night, maybe they need more processing time. In the morning, they might answer right away. And it might depend on what you're talking about. I mean, if you're sitting there talking about the Guardians game for 20 minutes, and then you start talking about changes in their medication, well, it might take them a minute to shift that change in topic. But if you go from the Guardians to then talking about the Browns, okay, well, we're kind of in the same sphere. So that shift is a little bit easier. So it's varied. Language is complex. And I just repeated to be patient. So patience is the best thing that you can do for anyone that's recovering from a stroke. They're going to be frustrated. They're going to be pissed off. A lot of it's probably going to be directed at you because you're there. Try not to take it personally. If you get frustrated and yell back, we're not going to be anywhere. We're just going to be yelling at each other and not want to communicate. It's going to cause shutdowns. Now, that doesn't mean that you deserve to be screamed at, but trying to give grace when you can. Yeah. Yeah, so the question, just for everyone on Zoom, was what to do when someone says forget it. And again, I don't want to cop out too much, but I'll say that it definitely is patient dependent. So more stubborn individuals, forget it might just be the answer. They might just be done. And again, circumstance, situation is everything. So I also try to just be very transparent with communication for that as well. So, okay, you're saying forget it. I can tell you're really frustrated. I really want to understand what you're saying, and I really want to be on the same page. Do you want to circle back to this later? Do you want me to give you a break to calm down? Are you willing to keep trying? And can we try something else? Can we get out a whiteboard and try and write something? Can you point to something? And we'll talk a little bit more about communication supports that might be helpful depending on the patient. But just trying to be clear that you value what they say, I find is helpful. So even if they're just like, I'm just so tired, like I can't come up with it. I need a break. Then that's acceptable. Can't make anyone talk to you. If they're ready to be done, then okay. But just being clear that I'm okay with you being done and okay with moving on, but I value what you're saying. I think it's important, and I'd like to know if it's too much for you right now. That's okay. We can move on. Again, being transparent, being clear. They're still adults. They're still people. So just talk to them how you would want to be talked to. Now, you might not know the exact situation, but treating them with respect and mutual communication, I find is the most helpful. But again, no perfect answer. It's very dependent person by person. And relationships matter too. If it's your parent that you're trying to communicate with, typically parents aren't willing to listen to their kids regardless of the situation. But if it's an aunt or an uncle or a sibling, you might have an easier time. And I find that professionals tend to have an easier time communicating with patients because there's that social contract of I'm here as a professional to help you. So I have patients all the time say, well, they won't talk to me, but they talk to you. Well, I'm here to talk. So they're willing to buy in, and we have to work through that and talk about it. Yeah, of course. Okay, so what's not helpful?
Again, ask them, was that helpful? Was that annoying? Did that make you mad? Was it frustrating? And you can tell sometimes if every time you talk to them, they just get mad and stop talking. Okay, well, let's think about what I'm doing. Maybe it's not helping. Jumping in if you know what they're saying and you complete their sentence for them or fill in the word is not helpful. It feels like they're being interrupted. They're treated like a child. So if they're sitting there and they say, "Oh, I really hope we're having," oh man, what was it for dinner? What would you have for dinner last night? It was and you just say spaghetti. Now, if it happens once or twice, okay, they might be okay with it because again, that communication two-way street. You're working together. But if it's every time they talk, oh, I'm really you say tired, and like okay, and or if they're talking to someone else and you're filling in those words, it's really frustrating. Again, just put yourself in their shoes. Um, if you feel like you would not appreciate someone completing your sentences or talking for you, um, they probably don't either. Now, if they ask you to, that's a different scenario. I've had patients with aphasia before where when they go to the doctor, they're just so overwhelmed. So they talk with their daughter beforehand and they say, well, when we go, I want to talk about this. You're like very active in my healthcare. You can talk for me. And typically they say, well, I'll try and talk, but if I need help, I'll just ask you for help. So again, just being open about what you're trying to do and where you're coming from and what is helpful for them is the best thing to do. Always try and wait. So again, back to patience. Unless it's an emergency, and it's very rare that there is something very emergent that needs to be discussed right at this very moment. We can't wait 30 seconds. Obviously, there are circumstances. So if that's happening, then okay, let's get going. But if that's not the case, then just wait. If they're stuck on a word, let them work through it. Hopefully, they're getting speech therapy or had speech therapy and have some good strategies to put in place to make sure they're communicating effectively. They're finding their words. They know how to fix that breakdown. But again, less is more. Taking more of a back seat once they're a little bit further in recovery is usually a good plan. So if you're talking too much, trying to fill in words, again, if you guess the word right, then you're golden. So if you're filling in the word and you say the right thing, then they're probably going to forgive you. But if you say the wrong word and then you guess the wrong word again and again and again, okay, well, now they're really mad because you keep interrupting them. You're not letting them work through it, and they're trying to process the information you're giving them, which isn't letting them work through that information on their own. You getting frustrated is not helpful either. That can be easier said than done, again, depending on the relationship. I find that kids tend to get frustrated with their parents, and spouses tend to get frustrated with each other, and that's just kind of the nature of life, right? When you're with someone so much, you bug each other. So trying to take a deep breath, trying to be the one that stays calm. If you both get frustrated, we're not going to get anywhere. So if you get frustrated, apologizing. They didn't ask to have a stroke. They didn't ask for it. I know that you didn't ask if it's a loved one, you didn't ask to be in this situation either. You're both in a crappy situation, so trying to work together to figure it out. I also find that can be frustrating for patients when they feel like their loved one is trying to be their therapist or their teacher. So I've had loved ones in the past who would sit in for a session and they want to know how to help. Well, when I do therapy, I work within like a queuing hierarchy. So I'm trying to give prompting to get to an answer. I know what the answer is because I'm asking a question. We're working on word finding. So then I provide support to get them there. It might be, okay, well, it starts with a B. And we're talking about color. Okay, well, blue. Or depending on the patient, there's different things. So I might use semantic cues with, you drive it, or a phonetic cue of it starts with a B, and that's helpful. But if a loved one starts doing that, well, they start saying it starts with "ba," it starts with "ba." Okay, well, that's not a normal conversation. So yes, using word finding strategies and communication strategies are important, but there's a difference between working together within the confines of communication and then trying to provide treatment, which can be frustrating. Again, just because there's usually a predefined relationship before the stroke, right? So if it's your parent or your spouse, okay, well, we don't talk that way to each other, so why are you doing it now? And typically the prompts are not always provided in as tactful as a way as a trained therapist would provide them. So I would say just keep in mind, would I talk to anyone else this way? If the answer is no, then probably shouldn't talk that way to the loved one or the patient that you're working with. Again, repeating questions numerous times. We talked about that quite a bit before, so that's just not super helpful. Okay, so when we talk about more severe circumstances, like I said, there's quite a range of deficits. So it can be anywhere from just having some mild difficulty finding words to no sound coming out ever, outside of groaning or moaning. Now, and everything in between. So these kinds of things can be helpful. Everyone that's in person should have a communication board that I've created, and that link, I believe, Lori put in the chat. So everyone should have access to it. It's just a very simple communication board to provide as just reference. So it really just depends. Now, so there's more complex, less complex, all depending on the patient. There can be lots of different things that work for communication support. If a patient has good cognition but just really can't produce words, then using those boards can be helpful to point to something and say, this is what I'm trying to say. Yes, no cards can be helpful. It can just be an index card that you wrote yes and no on, and you say yes, no. Anything to support communication. Give them choices. Holding up a bottle of water, a bottle of Gatorade, and saying, which one do you want? That can be helpful too. There's apps on iPads or phones that you can use. There's not a perfect one. I've had patients before where texting is fine and they can just text everything if they get really stuck. And there's full-fledged communication devices that are essentially very expensive iPads that have communication programs on them that are sometimes used for more long-term deficits. Okay. And then talking about supporting cognitive deficits, just briefly. Age appropriateness is something that I try to reinforce every chance I get. So talk to them like they're an adult. Don't give them toys that are intended for children. If you wouldn't appreciate being talked to one way, again, or if you wouldn't appreciate getting a Paw Patrol puzzle to do, they probably don't either. So just because there's cognitive deficits doesn't mean that they're a child. Trying to keep patients or loved ones engaged as much as possible. Don't just plop them in front of the TV. There's a lot of research to suggest that just sitting in front of the TV will worsen dementia or cause it to progress faster. Again, I understand all of this is easier said than done sometimes, and just recommendations to try and make it work as best as you can. If they really only want to do TV, then put on the Game Show Network, and they can play along to the game shows and be engaged that way. Watch Jeopardy, puzzles of any kind. Again, age appropriate, but puzzles are good. Cards, so if they like rummy, poker, solitaire, any of those can be good. Board games, audiobooks, anything cognitively stimulating is good. Again, there's different things, and every patient has a different thing they like. I've had patients that really like Legos, and that's what they do to keep their brain sharp. Some patients hate Sudoku but like crosswords. Some hate all of it and are okay with just having that regression rather than doing puzzles. And again, that's their choice. But trying to find something that's stimulating them cognitively to keep them active. Okay, and then just some resources. Lingraphica is a company that creates one of those very expensive devices that I talked about, but they also have a lot of free resources on their website. So they have quite a few communication boards that are much more complex than the one I provided. And they also have applications for iPhone and Android. Again, aren't perfect, but they're free. So you just have to give them your email, I think, and sign up for their newsletter, and then they'll send you all of their communication boards. So it's a nice resource that I come back to frequently. The local council on aging can be a good place to look if you're just lost and not sure what to do. I don't know every county and how good the local council on aging is. It varies county by county, but in general, they get called and ask these questions that you're probably having a lot. So can be a good place to start. Support groups can be good. having a place to talk about it. Maybe not right away. When it's fresh, it can be hard to talk about it, but as time goes on and they're learning to live with deficits, going to a support group. University Hospitals has monthly support groups for stroke and aphasia at UH Portage in Ravenna, and then at Ahuja up in Beechwood. I don't have all the information on me, but I believe a Google search will get you there for the exact information. And it's typically led by a speech therapist there as well. Tactus is an online, almost like online schooling, but specific to aphasia. It's a program that has exercises and different things. It's not something that I use frequently in therapy, but I have colleagues that enjoy it and certain patients like it. So again, it just depends on the person, but it can be a nice thing. The aphasia library is aphasia.com. It is owned by Lingraphica, but is a separate entity. Has quite a few videos, resources, links, connections, FAQs, things like that, all as it relates to aphasia. And then the last one is called Boardmaker. So that's what I use to create communication boards. Unfortunately, it's a monthly subscription. I haven't found anything worthwhile that I particularly like for free. Can also use PowerPoint and it works just fine. It's just not as pretty. So I like Boardmaker, but it's not necessary if you don't need something. But you can always get the subscription for a month and cancel it if you're making something specific. Yes. Yeah. So the handout was, I used Boardmaker to make it. And then Lori said that there is this QR code for the session to make sure everyone completes that before we get on to questions.
So our online people, if you would like to go ahead and drop your questions into the chat, I will give them to Austin. And I will also put the link in the chat here shortly for the evaluation itself. But go ahead and start putting your questions in the chat.
Yes.
So we cover this particular area, agency management. We cover Stark, Summit, Portage, and Lake.
Okay.
And you mentioned the support group for UH Portage in Ravenna. Do you have any support groups in Stark, Summit, with you guys, just Ravenna and then North?
As far as I know, there's not anything down south right now through UH specifically. I know that UH did just purchase Western Reserve in Cuyahoga Falls, so I think it's possible that there might be more of a push to come south. But as of right now, as far as I know, it's just that UH Portage and just the Ahuja for support groups. That support group is for those who have had aphasia and caregivers as well, yes. So sometimes it's loved ones will go with, sometimes the patient wants to go alone. It just depends. Yeah.
So we do have a question from Zoom.
Okay.
Younger individuals seem to be having more strokes. Is there a study of why?
Not anything that I am particularly familiar with. I have also noticed that as well. Nothing specific. I'm sure there's lots of research going on as to why, but it does seem to be becoming more common that I'm seeing patients in their 50s more and more frequently with strokes and severe strokes as well.
Any other questions from our online folks? Please drop them in the chat. Yeah, thanks, Patricia. That was a great question. And anything from our in-person people, I can run the mic around so our Zoom people can hear us.
The signs, fast, face, arms, do they come also before we get the stroke?
It typically is as the stroke is happening. So those warning signs will be, you'll see them as they happen. So as the stroke is actively happening, just like there's those well-known heart attack warning signs of the left arm tingling or the pain. So that drooping of the face, the slurred speech or change in speech, and that difficulty moving one side of their body comes with as the stroke is occurring. It can last for hours after. It's not uncommon for a patient who lives alone to be found hours later having that happen. Sometimes someone will wake up and start talking and they realize something's wrong. Sometimes they might be in the middle of a conversation and those signs appear. But as the stroke has already happened or is happening, will be when we see those warning signs.
Putting the nitroglycerin pill under the tongue be helpful at that time?
I am not sure. I don't know. I'm not sure.
Nitroglycerin
Oh,
pill.
nitroglycerin.
Yeah,
I'm sorry.
that
Okay.
opens up your
Right.
pipes.
I've heard of that for heart attack.
It's the same.
I'm not familiar with any guidelines on that, so I don't want to say anything that is not correct. But the reasoning does seem similar. Yeah. Yes.
I'm coming. Yeah, that just helps our Zoom people.
You had on several slides the wording self-monitoring. that They
Yes.
would have. What do you mean by that?
Yeah, so self-monitoring is a term that we use to talk about one's ability to listen to what they're saying and make sure it makes sense. So it's used a lot when we talk about kids. So kids with speech therapy is something that's a little bit more familiar. So when they're working on articulation, maybe they have a lisp and they never realized they had a lisp. Well, then we work on drawing their attention to it. Say, okay, well now instead of saying that word that way, let's say it this way. And okay, once you're really good at it, let's make sure you're using it all the time and you're paying attention to what you're saying. So when we talk about self-monitoring, we all do it naturally, even if we don't realize it. We make sure that what we're saying is said correctly. We're using correct grammar. It's just listening to what you're saying and identifying that, yes, that was good, or no, that wasn't quite right. So patients with aphasia sometimes don't self-monitor at all, where they're not listening to what they're saying, or to them it sounds perfectly normal, but it's not quite right.
And there is another online question. Let me get back to my computer here. Can the inability to control laughter or crying be a symptom of vascular dementia?
I think that is something that is pretty common in dementia across the board, at least in my experience. So it's not necessarily specific to vascular dementia. I do see it very commonly in patients with Alzheimer's, where that emotional control can be difficult. It can be hard as well, just because individuals as they get older tend not to care quite as much about regulating their emotions and tend to swing a little bit more. So it is something that I see in vascular dementia, but I wouldn't say it's specific necessarily just to vascular dementia.
Thank you.
But that inappropriate, so there's a whole nother aspect of stroke recovery and damage as well. So there's something called right-sided stroke, which could be a whole nother presentation in and of its own. But stroke is on the right side, it could impact that social component and higher level thinking, emotional regulation, things like that. So it is possible that a person might have vascular dementia due to a right-sided stroke and then just have that difficulty regulating emotions. So when I see a patient who's had a right-side stroke due to it, frequently will say, "Oh, well, they just start laughing out of nowhere," or swings. We're not sure why. Other things like just saying really inappropriate things to people that don't know self-monitoring, but again, there's a lot that goes into that. But it can hear that stroke and what that life looks like.
And then we've got a comment from Christine that says PBA is seen in many neurological disorders. And for my own nerdism, what is PBA to me? What is it?
I can't think of the middle word, but it's pseudo-bulbar or something like that, affect, where they are laughing, crying at inappropriate times.
Okay. Oh, yeah, she just put it in there. Thank you. Yeah, everybody's coming up. Yeah, pseudo-bulbar affect. Okay, thank you, everybody. And Elena, is your audio okay? She just said that the audio cut out. So, all right. So any other questions in the room, online?
I had one comment. Sometimes, you mentioned the stuttering and the slur, etc., or the silence between words. When we are learning a new language and the brain is functioning, trying to find the word in that new language that you're learning, I do the same thing.
Very similar. Any of that happening some of the time. I stutter occasionally. I don't stutter, but every person has stutter every once in a while. I can't help.
I'm going to do a tech check. We've got one person saying they can't hear you, they can hear me. So if somebody else on Zoom can let me know, Austin, can you just say something funny? How are the rest of our Zoom? Okay, something must have happened with your microphone. So it says they can hear me, but not you. So I'm going to give you my mic. Aha, everybody's chiming in. Nobody can hear you. Nobody can hear your wisdom. Trey.
Okay, so yes, so I guess I will repeat what I just said, in that any level of stuttering or some level of stuttering, word finding, difficulty communicating is normal for anybody. When it happens at a level that is impacting functionally, making it difficult for someone to communicate their wants, needs, concerns, happening on a more consistent basis is when we're concerned about it.
Okay, any other questions at all? Online, in person? And I will say too, if you think of anything after we wrap up today, go ahead and email me the questions and Austin, I can get them to you. And we do record each of these sessions and have them posted to our website if you would like to view them. Our website is www.dhad.org. And on the homepage, if you scroll down just a little bit, you'll see something that says I'm a caregiver. And that's where we have all of our caregiver support group information, our program here, and the recordings of these sessions. So you can feel free to rewatch that. And that's where we'll have the answers posted. The batteries in my microphone are dying. Thank you. But that's where we'll post the answers to as well if anybody submits after we're done here today. But thank you. I think I'm not seeing anything else come in online. So anything from our in-person folks? Yeah. Yeah. Thanks for coming in. We appreciate it. Yeah. We may have you pulled in before. I keep hearing great information. Thank you. So yeah, good stuff. All right. Thank you, everybody. Appreciate you being here.